Hello, let's learn about antimicrobial stewardship, the systems and the processes for the effective antimicrobial use. If we use antibiotics when not needed, we may not have them when we need them. Rightly quoted by Dr. Tom Frieden. The use of antibiotics is the single most important factor leading to antibiotic resistance around the world. Antimicrobial stewardship refers to coordinated interventions designed to improve and measure the appropriate use of antimicrobials, improve the patient outcomes, and reduce microbial resistance by promoting the selection of the optimal antimicrobial drug regimen, dose, duration, and route of administration. What are the 5 Ds of antimicrobial stewardship? One is diagnosis, that is does the condition require antimicrobial therapy? Drug, is the organism susceptible to the drug? Dose, what is the recommended dose? Duration, what is the recommended duration? And de-escalation, can the drug be switched from IV to oral or from broad to narrow spectrum? The primary aim of stewardship is to prevent the emergence of antimicrobial resistance and to optimize the clinical outcomes while minimizing the unintended consequences of antimicrobial use, including toxicity. A secondary goal of AMS is to reduce healthcare costs without adversely impacting the quality of care. Goal 1 is to combat the antimicrobial resistance, and goal 2 is to improve the patient outcomes. How to combat by restricting antibiotic use, which results in reduction of the antibiotic pressure, which in turn prevents the development of resistance. Restricted antibiotic use can reduce the colonization or infection with gram-positive or gram-negative resistant bacteria. To improve patient outcomes, it involves improving the inpatient cure rates, reduce the surgical site infections rates, reduce the morbidity and mortality. Goal 3 is to improve the patient safety through minimizing the unintended consequences of antimicrobials, reduce the antimicrobial consumption without increasing mortality or infection-related readmissions, reduce the Clostridium difficile colonization, reduce the healthcare cost towards antimicrobial expenditure without adversely impacting the quality of care. CDC recommends all the hospitals implement antimicrobial stewardship program, which involve the core components such as leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. How to implement the stewardship program? Assess the motivations, analyze your situation, what problems you want to address, have a SWOT analysis, that is strengths, weakness, opportunities, and challenges analysis. There are many guidelines available, but you will need to adapt them according to your local situation. Hence the SWOT analysis. What can be implemented depends upon the local needs. For example, simple clinical algorithms or prescribing guidance for treatment, IV to oral switch, IV antimicrobial batching, promoting education, and others. Then ensure the accountability and leadership, and to ensure to the successful stewardship program, the program should be supported by the senior leadership or the management of the healthcare setting who are accountable for the outcomes. A team of people and resources will be allocated by the head of the organization to implement and evaluate the program. These stewardship team members must possess power, expertise, and credibility and leadership. These individuals need to convince the managers and healthcare staff of the added value of. Then set up the structure, dedicated resources, multidisciplinary team, ID physician, a microbiologist, a pharmacist, and specialist nurses for inpatient control and stewardship. To, and then governance within the hospital, quality improvement and patient safety governance structures will be required. There needs to be a clear line of accountability between the various team members and the stakeholders, between the chief executive, the clinical governance, drug and therapeutic committee, inpatient control committee, and the drug committee. Then define priorities, the objectives of the stewardship program and how they are going to be achieved, and the measures need to be agreed by all the stakeholders. One way of doing this is to have a driver diagram. A driver diagram is like a logical chart with 3 or more levels, including goal, high-level factors called as primary drivers, specific projects and activities. For more complex goals, each driver should have its own set of secondary drivers. Like the driver can help a stewardship team to explore the factors that need to be addressed. So how the factors are connected, act as a communication tool, provide the basis for the measurement. Then identify the effective interventions for your setting. For example, core strategies could be formulary restrictions, pre-authorization, prospective audit, multidisciplinary team. The supplementary strategies will be streamlining or de-escalation, dose optimization, IV to oral, switch, clinical pathways, antimicrobial order forms, education, computer decision support, lab surveillance, and antimicrobial cycling. Then the multidisciplinary team consists of the ID physicians, then clinical microbiologists, information system specialists, clinical pharmacists, epidemiologists, and inpatient control professionals. The goal is they need to have a shape to share the goals such as minimizing the resistance. They need to have expertise in the initiative development, liaison for the delivery initiatives, expert in analyzing the data, support the research, compile the raw isolates and data, implement the micro-driven initiatives. A team game with the patient at the center and its teamwork that makes the dream work. Core elements of the stewardship will include enhancing the infection control, control the source of infection, prescribing antibiotics only when they're truly needed, prescribing appropriate antibiotics with adequate dosages, using the shortest duration, reassessing the treatment when required, when available, and supporting the surveillance of AMR and IPC. Educating the staff and supporting interdisciplinary. The primary strategies include formula restriction of pre-authorization and prospective audit. The secondary strategies include education, clinical pathways, antimicrobial cycling, order forms, de-escalation, and IV to oral switch. So before treatment, have a formal restriction. After treatment, audit with the real-time feedback, IV to oral switch, and de-escalation from broad to narrow. And then I have audits and reports on education and guidelines, de-escalation and rapid testings. So this is like a before treatment and after treatment table, and then active interventions and passive interventions. This strategy framework could be followed in the state of stewardship. So advantages of the prospective audit is that it reduces the inappropriate usage of antimicrobials, serves as an educational purpose, allows prescribers to maintain autonomy. And then disadvantages is difficult to identify patients with inappropriate therapy and communicating with the prescribers. We can have a formal restriction, but it may result in immediate and substantial reduction in the usage of antimicrobials and costings. But it may increase staffing requirements, may delay the orders, may increase use of and resistance to alternatives of antimicrobials. Education may influence the prescribing behavior and promote acceptance of the strategies. However, it is very marginally effective. Evidence-based guidelines may improve the usage, but adherence is very poor. Antimicrobial cycling may minimize the resistance. However, there is insufficient data for the same. Antimicrobial order forms may reduce antimicrobial usage, but there is potential for inappropriate interruption in therapy due to automatic stop orders. Combination therapy may improve the clinical outcomes, but is often redundant and unnecessary and is available. Streamlining or de-escalation therapy reduces the exposure. The prescriber returns to de-escalate is an issue. Dose optimization tailors therapy to patient characteristics or nursing staff concerns about incompatibilities during for infusions. Then parent to oral conversions may decrease the length of stay. However, there is a difficulty in identifying those patients. That is about the advantages and disadvantages of the different AMS interventions. The IMS recommendation by ICMR includes structure, that is have a team, multidisciplinary team, have the capacity such as monitoring, reporting, auditing, and computer technology, have antivirograms and antibiotic policy, have formularies and guidelines, have trainings, have monitoring and reporting antibiotic usage, goals and measurable outcomes. There are two important processes to monitor the results, which include review of the prescription, lab results, clinical notes, and most importantly, audit of carbapenems and polymers using ICU. Intervention therapy based on standard guidelines and patient clinical status will be ensured to control use of restricted antimicrobials for empirical therapy. In education should include stewardship program as part of the main course of syllabus for all the physicians, microbiologists, pharmacologists, nurses, and pharmacists. Research should focus on novel strategies of stewardship, implementation, and impact of stewardship program. So this is how the cycle looks like from the patients. So this is the test reporting, test processing, test ordering, and others. Is AMS possible in India? Yes, it's possible. How the antimicrobial resistance is a crisis in waiting. As the bacterial infection grows, it is becoming more and more resistant to antibiotics. Companies are pulling out the antibiotics research, and very few antibiotics are being now available. India is moving towards a post-antibiotic era, and India has an antibiotic problem. India is the largest consumer of antibiotics, and many leading cause of morbidity. The resistance is like leading cause of morbidity. The mortality is like a silent pandemic going across the globally. This is kind of that is here in present is a special article called as Antimicrobial Stewardship Program from Policy to Practices. When a survey of the stewardship program practices from 25 centers in India was reported in the year 2019. It is published in the journal Academic Clinical Microbiologist. 11 were government centers. 15 the stewardship program was led by physician and clinical microbiologist with meetings in a year and monitoring the IT software. 14 centers who net in place. Wards rounds that taken prescription audit feedback and antibiotic consumption data was provided. Indian perspective is that 40% higher in the Indian ICUs than the general. The barriers and facilities to stewardship program include lack of the key personnel like such as clinic IT physicians, problems with the data information system, the influence of adequacy of financial resources, lack of time, inadequate supply of lab provisions, problem of limited antibiotic, lack of knowledge, lack of willingness, like reinforcement is required, skills an issue. Increasing awareness among prescribers is a necessary imperative. Effective adequacy, pocket guidebook, laminated posters, newsletter, posting, smartphones, education, training, empowerment, networking is in microbial resistance. AMS awareness factors needs to be put in place. Similarly, for infection control, and professional learning factors needs to be in place. Behavioral factors needs to be emphasized. AMS awareness factors such as changes in the professional norms. Behavioral factors like identifying the clinical need, providing clinical education, use of diagnostic tests, accurate prescribing, enhance infection control measures. Constitute the the five components of the behavioral changes. If we see the structure, process, and outcome triad, the structure process will include antibiogram and antibiotic policy and multidisciplinary team and training. While the process measure will include stop and review date or de-escalation, documented indications, length of therapy, compliance, surgical prophylaxis, and others. But outcome will include the length of the stay, the rate of organization pathogens, the mortality, morbidity, and antimicrobial consumption.